So you can go for live, actually 805 now, as per our format. We will go for live. We'll wait for 50 participants already. It's live.
Okay, sir. I have once calling now. Sir, do I need to share my screen also, sir? Like my video, like.
You have to.
I see. Good evening, sir. Good evening, sir.
Hi, Shrikant. Samita here.
Good evening, ma'am.
Good evening.
Ma'am, can I start the presentation now?
Nalini, are we ready?
Yeah. Presentation will start now because already the participants are there. Just waiting to sit down, but probably join in the meantime. Not an issue. So good evening, all of you, all the trainees who joined and the faculty joined today in the session. As we know, the NOEL is a weekly training session is going on for the last 3 years in the 4th edition of the session of NOEL. We welcome in the neurology series. Today is the presentation about a preterm brain injury, and through the case presentation, we will try to learn the practice points which will help us in preventing and treating the preterm brain injury in the form of IVH, and how to optimize the prevention strategies, and how to learn through our discussion, and how, if there is a complication, how to manage it. We'll learn through the process. So to continue the session today, the presenter, Dr. Shrikant, the neonatal trainee and a trainee fellow from Rainbow Children Hospital, is going to present a case, and to guide the session, two of the eminent neonatologists we got today as faculty, as a facilitator. So Dr. Famita from KIMS Hospital, Trivandrum. She is a neonatologist and well known in the neonatology arena. Multiple times he has done moderating and the faculty facilitator in the NOEL session. You probably all know her. So she has done multiple times the sessions in different format of NOEL, 3 formats of NOEL also. She participated with her expert inputs. We have learned a lot of things. We expect same thing here. And to add and to enhance the session, today another senior neonatologist, Dr. Sriram, is senior neonatology consultant from Paramita Children Hospital, Hyderabad. So he will be also shortly available. So both the faculties now, they will lead the discussion session. The format is such a way that it is not like a didactic teaching. And throughout the presentation, when Dr. Shrikant is presenting, both the faculties will try to interact so that throughout the session, the learning will happen for the trainees. And we expect a great learning session. With that, I will just invite Dr. Famita if she wants to start the session with few words. Otherwise, Dr. Shrikant can start the session presentation and throughout will interact.
You can keep it, otherwise you can. Sorry? We can just start.
Yes, start in the meantime. Just if any discussion point of time, I just request both the faculties, please, you can stop the presentation and just the practice points or the learning points to be highlighted for the presentation. That's just my request to go through the session.
Okay.
With this, thanking all of the faculties and the student, let's Dr. Shrikant start the session.
Okay. So good evening, sir. Presenting the case of IVH. Presenting the case of IVH, and that is baby of M and current day of life 124 was admitted.
Sorry to interrupt. Shrikant, sorry to interrupt. You to switch on your video. Throughout the presentation, the presenter video switch will be on. Yeah.
Presenting the case of IVH, and that is baby of M, current day of life 124, was admitted to NSU in the view of extreme prematurity, 24 weeks, and extreme low birth weight 620 grams with respiratory distress syndrome. And coming to the antenatal history, obstetric history G4A3, and mother ages of 30 years, and via spontaneous conception, that is of non-consanguineous marriage. And coming to the A1, A2, A3 details, they were like miscarriages at 6 weeks, and that through IVF conception. And G4 is present pregnancy, that is through ICSI conception. And she had regular antenatal checkups, and investigations are advised elsewhere. And coming to the first trimester, viability scan showed DCTA twin gestation, and that is on there was spontaneous fetal reduction done at 9 weeks, and regular sugar monitoring was done and was within normal limits, and there was no history of fever with a rash. And coming to the second, third trimester, quickening felt at 4 months, had 2 doses of TT injection, diagnosed with gestational diabetes, 20 weeks, and was started under diabetic diet. And no history of PIH, antepartum hemorrhage, urinary tract infection, polio oligohydramnios, or no history of PPROM. And mother has not received adequate antenatal steroid coverage, and mother has not received MGSO4. And coming to the birth history, it was 6. Ma'am.
Can I interrupt you?
Ma'am.
Yeah, she can't just just a suggestion. It's not that you have to follow the same protocol or performer for presentation, but you're now a postdoctoral student, so
Yes,
you can change the style a little bit so that
Okay,
you
ma'am.
focus on what's important. So from the first 2-3 lines that you said, Shrikant, I just got the impression that baby is ELBW and is 124 days old, but I have no idea what is the status of the baby just now. Okay, so you might want to just introduce the current status of the baby in a half a sentence or first sentence itself when you're starting off the case. 124 days as what? Is he just a growing preterm? Is he somebody who's post-operative? Is he on ventilator still? Is he a BPD? Something like
No,
that.
ma'am. Current status, baby has been discharged, and baby was on follow-up, ma'am. And baby is like hemodynamic stable, and there were no issues, ma'am. Like like baby is on like daily, like on continuous like follow-ups, ma'am.
Yeah, so that would be a good
Well,
idea to just reframe the first sentence. You say that I am now presenting a 620-gram baby who is now 124 days of age, had a course of illness involving RDS, currently has been discharged and is on follow-up with dash 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 problems, something like that. Just an idea suggestion only, so that different type of examiners will have different styles, but this will take away a lot of people's feeling that you are talking like a undergrad or a postgrad student. You're beyond that now, no? So like that. The second is that when you put your second slide on, Shrikant.
Yes, ma'am.
Yeah. So here I can see 2-3 things that are probably maybe less relevant. If you think it is relevant, then you have to have a pointer to justify why you put that point there. One is the quickening. Okay. She's primary. I don't know what would be the relevance of quickening. The second is TT injections. Is it TT still or is it DTAP still?
DTAP, it is like.
Yeah. So you'll have to be more specific there. You'll just jump into some queries, questions about things that we may not have read too much about if you don't put accurate information. The second is that, is it spontaneous fetal reduction happened at 9 weeks? Should be that way,
Yes,
no?
ma'am. Like they have taken the scan at 9 weeks, ma'am. Then they were told about the spontaneous fetal reduction.
That's right. So it can't be done at 9 weeks. It would be happened at 9 weeks. Okay. Yeah, go ahead. These are not criticisms, Shrikant. I'm just suggesting.
Okay.
Yeah, go on.
And coming to the birth history, baby was 620 grams, female baby, delivered at extreme preterm and via spontaneous vaginal delivery that have like delivered on 18th of December 2023 at 9:35 p.m. And baby, like after delivery, baby had post spontaneous efforts for which baby was started on positive pressure ventilation for 1 minute and intubated and was shifted to NSU for further management.
So this is an inborn baby.
Yes, ma'am. Yes, ma'am.
Yeah, so that would be a good point, no? When did she come to you antenatally, the mother?
Ma'am, antenatally, it
So
was
whether she came
no.
in just imminent delivery and you had to deliver off, or whether you had the opportunity to give, probably no, you've written no ANS covered. She must have
No.
commenced at that point. So you might want to mention that, because for your case, both are relevant. That ANS was not given, Maxalf was not given, and that the mother came to you antenatally. One negative, one positive, right?
Okay.
Yeah. So you were there for the delivery, your team was there for the delivery, right?
Yes, ma'am. Our team was
Yeah, so that's again a positive point, no? So you can start talking about positive negatives in the history itself. You say that
okay.
ANS could not be covered, Maxelf could not be given. However, the baby, pregnancy was antenatally transferred, and a trained neonatology team was available for delivery.
Okay.
Yeah. Go on. Yeah.
And on admission, baby was admitted to NSU and started on PCAC mode with volume gradient.
I'm just holding back here. As Dr. Amita asked actually. So same thing I will ask you before going to admission and for the care of the baby till the perinatal delivery room. You can summarize this baby is going to born with such a biological risk factor of extreme prematurity, and the birth weight is such a low birth weight of 600 some grams. So what are the positive things happen to the baby which going to protect and lessen a few of the morbidities? And what are the things happened here till this time where we are expecting that with in absence of those care or in the presence of those factors, the morbidities of this baby may be a little bit more. To clear the idea, can you summarize what thing good thing happened and what bad thing happened to the baby, which can decide the morbidities later?
So, and like regarding the bad, like baby didn't like mother has not received antenatal steroids, and mother has not received MGSO4, like that will be a neuroprotective, and the previous bad obstetric history.
Go on. You have it all. Tell.
Yeah.
Some more. What was the mode of delivery, Shrikant?
Ma'am, vaginal delivery, ma'am.
Yeah. Is there anything to suggest that any mode is better for a 24-weeker? Yes, no, not sure. Anything is okay. Like if you were asked as a neonatologist and the obstetrician is a new person and she asks you at 24 weeks, especially where people are still not sure about outcomes, your unit is doing standard care for 24 weeks, I presume. Therefore, if they come and ask you what mode do you prefer, do you want us to deliver by CS or by vaginal delivery, what would you tell them?
Vaginal delivery, ma'am. Like.
Okay, can you qualify better?
Yeah, same thing. Just I was going to ask which mode is you are thinking is better than other mode, or they are equally they're good for the baby, or they're equally bad for the baby. How it is? How do you decide? Or I ask you specific some questions. Specific question. If the normal delivery happened this baby, so do you think this normal delivery can introduce few of the morbidities in such a small baby in comparison to the cesarean section? Or there no role, just you do whatever, you wait for normal delivery or electively do a cesarean section, and the morbidities of such a 24-weeker will remain same. Do you believe they remain same, or few of the morbidities, talking about RDS, talking about NEC, talking about IVH, talking about any injury to the baby? How you think they are equally?
To vaginal delivery, there are chances of any birth traumas.
Is it lesser in CS? You think CS is easier in a 24-weeker, Shrikant? Just easy, some questions only. Think. Actually, term baby would be easy to deliver by CS, but 24-weeker also will be floating inside only. It will be as difficult to deliver by CS, a 24-weeker. But if you have, suppose for hypothesis sake, this was a twin gestation, Shrikant, and there were really two live babies at 24 weeks. One was presenting transverse, the other was presenting breech. something like that. And if your obstetrician now asks you, what do you want to do?
Like in thin gestation, like better to go for LSCS.
Yeah.
Because when it was
Yeah.
one is of each presentation.
Correct. So I gave you two qualifications there. No, one is that if you have a multiple gestation at a periviable multiple pregnancy at periviable gestation, then there is a role for cesarean section.
Yes,
The
ma'am.
second is if there's a malpresentation, then also there is a role for cesarean section.
LSCS.
Yeah, but if you have a baby whose mother who's just coming in imminent delivery and who may just deliver vaginally, and at 24 weeks the family is not really sure about whether they want to go ahead with the baby or not. If you are also not sure that the outcome is not going to be great, then there's no evidence to suggest that in such a case that the outcomes may be better in CS. There's no clear-cut evidence. But 2-3 things are clear. One is your neonatal team is ready, more in case of cesarean. If
Yes,
you have
ma'am.
a multiple gestation, and if it is periviable or preterm, extreme preterm, then yes. If it is a malpresentation, then yes.
Presentation, that is
Okay.
also.
So the other things are all query. So if you have
Okay.
just one baby, it's cephalic presentation. If you have
Yeah.
a mother who's anyway going to deliver vaginally, then you may not be justified in saying that cesarean will lead to better outcomes. Okay.
And
Yeah.
Srikanth, last previous slide you go, and another factor you've written highlighted, probably that's also you can say.
Yes.
You can go there. So what's the previous? No. Next slide. Yeah. This slide, one spontaneous vaginal delivery. One point we discussed well. The other thing you highlighted, what do you think? That's a good
That
thing happened.
baby didn't have that post spontaneous, like a baby didn't have spontaneous effects after delivery. So that is also like.
Yeah, very
So
good.
baby,
If the baby is vigorous, then it is actually a good prognostic finding. And what else
That
can you
is
do
of
if the
preterm baby and low birth, extreme low birth weight.
Yeah. If the baby's vigor is good. Actually, there is one British guideline, old one, which says that if the vigor is good at birth for periviable gestation, then the outcomes and your intention to resuscitate should actually be positive. So what else can happen, Shrikant, or what could you not do because the baby had poor spontaneous efforts at delivery, which might have improved outcomes? You took him and you immediately ventilated him, no? You had to intubate him. So what could you probably not do, which might have helped that baby if he had breathed well?
Not,
What about cord management, Shrikant?
ma'am, cord management.
Could you have done DCC?
No, ma'am. No, ma'am. Like extreme preterm and which like when the baby had no post spontaneous efforts, like cord milking and delayed cord clamping is not indicated.
Right. So because baby had poor spontaneous efforts and you gave priority to resuscitate the baby, you
Resuscitate.
would not do
Yes, ma'am.
DCC.
Yes,
If this
ma'am.
baby, again, for just discussion's sake, was breathing
Ma'am, then cord milking.
out with a reasonable cry and was moving, then would you have attempted DCC? Milking, you're right. Maybe there's no evidence about milking it. You can't do milking. The conventional milking you can't do for less than
Yes,
28
ma'am.
weeks
Less than
gestation.
28.
But can you do DCC?
DCC, yes, ma'am.
You can, no? Yeah. So if it was 24, 25 weeker with good efforts, then DCC could have been attempted. That advantage this baby could not get. That's what sir is asking. One is poor spontaneous efforts itself is not good. What is the reason for poor spontaneous efforts in any extreme preterm, Shrikant? Is it asphyxia?
No, ma'am. Like, maybe due to RD, ma'am, respiratory.
Very good. Yeah. So usually the reason for no respiratory effort is not because of asphyxia in a preterm baby, no?
Respiratory,
It's
yes, ma'am.
because of a bad lung only.
Yes, ma'am.
Yeah, correct. Go on.
Ma'am, on admission, baby was admitted to NSU and started on PCAC mode with volume gradient 5 ml per kg, and that we kept on ventilator settings of Pmax 22/12 and P5 and rate 15, and cord gas was 7.25 and PCO2 44, PO2 58, and base excess of -3 and bicarb of 19, and BPs were at the 25th centile, and we have given LVSQ suffectant was given, and after 2 hours ABG was 7.38 and PCO2 29.5 and PO2 39.9 and base excess of -6.9 and bicarb 18.9.
Is this an
And
arterial blood telling Shrikant, or is UVC or a cord gas?
Arterial. Arterial.
Okay, so you had a
Nice.
UAC case already. Umbilical artery line must have been there, no?
Yes, ma'am.
Sure.
Yes, ma'am.
Okay. Now I'm going to ask you why you call it cord gas. You would have just said umbilical arterial or
Ma'am,
arterial.
to rule out any perinatal insult or
Yeah. So again, question, is it from the baby postnatally, or did you take it by the proper method of double clamping? I'm just trying to teach a point here.
ma'am, through the method of double clamping, ma'am.
Okay. So
We
you
need
let
to-
one team resuscitate the baby and another team must have taken the cord gas, no? Otherwise, what's the meaning?
Yes, ma'am.
Yeah. So how do you take a cord gas in term, preterm, whatever? Just describe what is done usually, this double clamping method.
First double clamping is done, and the pulsation, like we need to check for the pulsations of the cord.
Okay.
And
But you clamped it, no? She can't think.
um,
You clamped it from the baby's end, no? So you will not get pulsation after that. Huh. Okay, you have a piece of cord with you with two clamps on either end. Now what do you do? Okay, you will sample from two vessels. Okay, so the one which you sample usually more easily will be from the umbilical vein, because that's very patulous and easily you can sample. So the actual method of doing a cord gas after double clamping is to do a double sample. You have to take from two vessels. So the easier one which comes is usually the umbilical vein, and then you'll have to take some effort and take from the umbilical artery which you have clamped. Remember, it goes into spasm as soon as the baby is born, or as soon as you clamp. So it's very tough to get a sample from the umbilical artery. So the importance of doing that is that when you do a blood gas analysis, the two results that you get from the two vessels should actually show a minor difference. Then only you can prove that one sample has come from umbilical vein and the other has come from umbilical artery. And the umbilical artery is the one which is representing the baby status just before delivery. Correct? It's the umbilical artery, no, that you want. Umbilical vein.
umbilical vein.
What? Yeah. Umbilical vein will represent what? It's only placental circulation, right?
Yes, ma'am. Placenta.
Yeah. Because blood is coming from where to where in the umbilical vein?
Ma'am, like from mother to
Baby. Correct.
yes, ma'am.
Yeah.
From mother to the fetal, ma'am. Like
Correct. So if you take only one sample and it happens to be from umbilical vein, then you're actually maybe getting a better value than actual baby status is, because UV has higher what? Higher pH than UA, and UV has
we
lower CO2 than
lower
A.
CO2.
Okay, right. So you have to show and demonstrate a minor difference between UV and UA sample, and then only you can say that one is come from umbilical artery. Now, why this point is, this may not be relevant to your case, but this is relevant if you're dealing with an asphyxia case.
Yes,
So if
ma'am.
you want to protect the obstetrician and you want to show that the insult was not perinatal, then you have to have a UA sample that has a good pH and a good basics.
And basics.
Okay. Yeah. So this cord gas is probably not cord gas. It must be umbilical artery, I'm presuming. Okay, because there's only one. All right. Yeah.
We can just to continue the discussion and agreeing with Dr. Pramita, I just want to say here that if the cord, this is umbilical cord gas, why it is written when baby was admitted to an ICU, started the treatment, then cord gas came. If your sequence of presentation, cord gas is a investigation and delivery room. So if I will like to present the data, I have to present on not on admission. Before admission to an ICU, delivery room, the sampling taken cord gas. So cord gas itself is wrong word here, and it is not a cord gas. Very relevant finding here. You are saying 7.25 pH, 44 PCO2, 58 PO2. 58 PO2, is it possible in umbilical artery in any context? Even though we 100% FI to bagging the baby before disconnecting, the PO2 crossing more than 30 is not a umbilical cord artery blood. If a more than 30, it's a mixed with venous or a venous blood itself. Maternal blood possible 58 PO2.
Yes,
But a fetal blood who lived with a low PO2 whole throughout last 24 weeks, how suddenly will be 58 PO2? So the value itself is two contradiction here. The presentation is, so it is not cord gas. It may be the initial gas during the IV line or during the UVC placement when somebody has done a gas. And later 2 hours after, again did a gas, which clinically 2 different times you got the gas you were presented, because that's a sequence. You probably may not there in the case, you don't know, but the after admission to an ICU, it cannot be umbilical cord gas. The umbilical cord gas has to be at the delivery room when the baby we are delivering within first 5 minutes of resuscitation. When we are stabilizing the baby, somebody gives a value of umbilical cord gas. And they itself always remember, is a learn teaching for everyone. I'm saying here, if you got a arterial gas and you are saying your PO2 is high, more than 30 or 35, think once. It may be when you are putting the needle, it has probably hit the vein also. So mixed sampling possible, or a completely venous sampling from the mother, not arterial sample at all. If it is crossing any point of time 30 or 35 PO2. So that's way to cross check how the sampling was right or not. But many a time ideal way, the Dr. Amita has guided ideal way to do 2 sampling from 2 vessels. So we can say, okay, this is a maternal sample, this is a baby sample. But if one single sample we need, that's the umbilical arterial sample, not the venous sample. But we are interested in baby and the fetal circulation. And is it correct or not to know? That's the PO2 is the clue here. The PO2 crossing more, then it's a mixed sample or it's a venous sample. It is not arterial sample. Okay. So with that, actually, you are presenting. If Dr. Amita any points, you will continue. Otherwise, you can go and continue.
Continue. Yeah, Shrikant.
Can I
You tell
continue?
me about your 2-hour gas, you were there.
Yes, ma'am.
Want to say something about the last gas? Any comment? Something wrong? Something could have been changed in the last gas 20 after 2 hours? You got a value of 7.382 with a PCO2 of 29.5. PaO2 or PaO2, no, whatever. Is there something wrong in the first 2 values itself? PCO2?
Like more CO2 is like wash out, ma'am.
That's correct. What would you target actually, Shrikant, if you were on duty?
Ma'am, like we should not hyperventilate.
Absolutely. So what did you target? What would you have liked there as a value?
Like we can come down and wait.
You want a value of PCO2 between what and what, Shrikant?
Ma'am, like 35 to 45, ma'am.
Okay. So you definitely don't want less than 35, right?
Yes, ma'am.
Yeah. Would you like a PCO2 60? Is that okay?
No, ma'am. Like hypercarbia, it
Is also a problem?
problem. Yes, ma'am.
Then what is this permissive hypercarbia, Shrikant? What is permissive hypercarbia? You allow
Yes.
CO2 to be high as long as the pH
Yes,
is
ma'am.
reasonably good, 7.25 odd, but you will not allow permissive hypercarbia in.
With normal pH and like the more PCO2.
That's correct. If you have a normal pH and if you have a CO2
With
which is
more
higher,
PCO2 greater
that
than.
is called permissive. You're allowing it to go up as long as the pH is okay. But in the first 3 days, first 4 days, first 5 days, you do not want even permissive hypercarbia.
In the first week. Yes, ma'am. Yes, ma'am.
Yeah. Why is that? Why is that?
Ma'am, there were the like chances of IVH hypercarbia causes.
Very good. So you think the risk of IVH is the highest in the first 3 days, 4 days, 5 days, whatever,
Yes,
even
ma'am.
1 week
First week.
maybe. So
Yes,
when the
yes.
baby is in a sick status in the first few postnatal days, we do not use the term permissive hypercarbia. We want it to be normal. You don't want it to be high.
Yes, ma'am.
Okay. Yeah.
Yes.
So somebody has put Kushwant has put a correct point that, and that is what you have also said, that why does it cause more risk of IVH, hypercarbia? Why does it cause more risk?
Ma'am, increased cerebral
Blood flow, right?
yes, ma'am. Cerebral blood flow, ma'am.
Yeah, so it kind of alters or it disturbs the autoregulation.
Yes, ma'am. That fluctuations in the cerebral blood flow will be the one of the cause of IVH.
That's correct. So I'll ask you a very basic question. What does CO2 do to the circulation in the brain and in the lung? And what does oxygen do to the circulation in the brain and in the lung? You said the half answer already. A high CO2. Let me qualify that. What does a high CO2 do to the lung and the brain?
Like causes ischemic.
High CO2 causes vasodilation or vasoconstriction in the brain. Just now you told, no? The answer. High CO2, brain, what happens?
Vasoconstriction, ma'am.
You told me it increases cerebral blood flow, no?
Yes, ma'am.
Yeah. Don't
Yes.
worry. Why are you getting stressed out? You know the answer, no? Huh. Yeah. So CO2 increase, vasodilation in the brain. What
Vasodilation.
happens in the lung?
Vasoconstriction, ma'am.
Yeah. How do you remember that? Because they used to do what? They used to hyperventilate babies who had pulmonary hypertension, no? Long back.
Yes, ma'am. Yes, ma'am.
Yeah. So CO2 has got a vasodilatory effect on the brain and a
Vein
vasoconstrictor
and
on the
vasoconstrictive effect.
lung. And O2 has the opposite effect, no? Low
Yes,
O2
ma'am.
causes vasodilation in the brain and vasoconstriction in,
Yes,
right?
ma'am.
Yeah. So hypoxia causes pulmonary hypertension, right?
Yes, ma'am.
By vasoconstriction. Hypoxia causes brain vasodilation. So in the first 3 days of a periviable or an extreme preterm, you do not want to hypercarbia, you do not want hypoxia. Correct?
Yes, ma'am.
Yeah. So then, why do you don't want hypocarbia then? This which is what has happened to you in the first 2 hours.
Ma'am, hypocarbia, like respiratory causes will be affected.
Okay, good. You don't want to cause lung damage. That's fine.
Yes, ma'am.
Maybe
Yes, ma'am.
hyperventilating him. Right. What else are you doing to the brain? The reverse of what happened previously. Hypocarbia will cause cerebral
Cerebral reversal of vasoconstriction.
correct. Right. So you can
Yes,
have
ma'am.
ischemia there.
Yes, ma'am. Ischemic.
Very good. Very good. Yeah. Sriram, hi Sriram ji.
Hello, how are you?
Good, thank you. Please, I'm just going on and on because I'm continuing.
No
That's all.
problem, no problem. You can
Yeah,
continue.
yeah. Go on, Shrikant. Yeah.
At 10 hours of life, baby was continued on PCAC mode with VG and on the on the ventilator settings of Pmax 22/12 and peak 5 and weight we have decreased to 40, and after that ABG was 7.36 and PCO to 41 and PO to 23.1 and basics is -1.2 and PICAB of 20.1. And coming to the chest X-ray, 8 spaces expanded and vitally stable and BP at the 5th to 25th centile, and coming to a CNS AF at level, and investigations where there was a decrease in the hemoglobin level that is of 11.5 and one LRBC was given, and platelet at 2.5 to at normal level, and INA was 1.4 and APTTP was 62 and FFP was given, and serum bilirubin level of 5.1 due to which the fourth therapy was started, and sodium level of 149. On 39 hours of life, that is of post-menstrual age of 24 plus 2, continued on PCAC plus VG mode on PIP of 21/21 and PEEP 6 and weight 60 and VG of 4.5 ml per kg. During the course, the ventilator requirement of ventilator settings were increased, and that is of PIP 21/21 and FI out of 30, and then the ABG was pH 7.191 and PCO to 59.5 and PCO to 72.7 and base excess of -5.1 and bicarb of 19.2. Then we have shifted to HFO with the settings of frequency 10 and MAP 11 and delta P of 20. Then after 2 hours of ABG was pH 7.41, PCO to 31.1 and PO to 55.5 and base excess -4.5 and bicarb of 21 and hemodynamically stable.
I'm not familiar with the terminology 21/21 and 21/12. Can you explain it to me? PIP of 21/21. Just tell me what you meant by it. You have put PCAC plus VG, pressure control assist control mode, correct?
Yes, ma'am.
With volume guarantee. So
Yes, ma'am.
what is PIP 21/21?
It will be the PIP with PEEP, ma'am, like 15 plus 6, that will be 21/21. That will be the inspiratory.
Okay, pressure above PEEP is 15. I got that, maybe.
Yes, ma'am.
21. Why are there two 21s? Or the next line you have written 21. In the previous slide, you had written 21/12, I think. What does that mean? Is it like the pressure the machine is taking, or is it a PSV along with PCAC? What does the double 21 mean, Shrikant?
Probably it is P max he's talking about.
Okay, Sriramji, I didn't know why there are two. Yeah, I maybe the machine baby is taking 21. Does that mean that for VG of 4.5 ml per kg?
I think the P max is 21 and baby is requiring 12.
Correct. So yeah, okay. So
Probably.
then in
That's
the
what
next,
I understood. I think Nalini can clarify.
yeah,
Let's Srikanth clarify. He has written 21/21. If it is 21/17, how to explain? If it is 21/21, how to explain? Let's see.
Yeah, I think he should explain because he has made the slide.
Seeing SCBG mode or SIMBBG mode. So if this finding written 21/21, if this somebody has written 21/17, how to explain? Srikanth?
So like the requirement of PAP will be along with the PEEP, that will be 21. And
For that, it will be only one variable. Na? You cannot have two variables.
there are two clues that have come in, Shrikant. One is that you told that it is a VG mode, na?
yes,
So
ma'am.
maybe baby doesn't need 21 all the time. That can be one clue.
Yes,
Is the
ma'am.
baby taking lesser than 21 maybe to achieve 4.5 ml per kg? And that may be one clue. Second clue is that probably you have an add-on pressure support ventilation and the rest of the pressures are maybe supported lesser if it's 21/12 or 21/17. I'm guessing really.
Here actually he has written the PC,
Here, the mode is AC. Na?
assist control, though, so no
Yeah.
support
So
will
no
be there.
PSV addition
All
will be there.
Correct.
all
Yeah.
the triggered breathing will be all the triggered breathing will be go to the 4.5
only.
per kg.
Yeah.
But for 4.5 ml per kg, one good spontaneous breathing may require 15 pressure. One baby, when is less spontaneous breathing effort, babies might require 20 or 19. There is a variability of PIP requirement, but the upper limit of 21 set is 21. What he meant probably, because the chart, ventilation chart, because the case patient from our unit only, the ventilation chart always the nursing staff writes what is the upper limit of maximum set PIP. And that second one, 21, 19, 17, hour-wise, they go on monitoring the baby, pre-surfactant, post-surfactant deterioration. We will know that how much actually pressure required on the particular on that time for to deliver that 4.5 ml per kg. That's the way actually I was giving hints to Srikanth. If a 21/21 means baby is requiring 21 pressure 4.5 ml per kg. After few hours, if baby is requiring 21/17, means your set is 21 upper limit, but now baby has improved lungs wise, requiring 17.
8.17.
You have given surfactant, it is 17 pressure requirement. Slowly, baby again deteriorated over next 12 hours. Again, going up towards 19, 20, you can say lungs probably deteriorating. Same 4.5 ml per kg. Depending on the required pressure, you can choose, you can know and judge and assess the baby's lungs deterioration or improvement. That's the way from the ventilation chart you will know, but you should know how to interpret it because it may be different units, they may be writing differently. Because the unit where you work, you may be taking from the nursing chart, from the ventilation chart, but you should be able to explain so that all will understand. Okay, it is the assist control mode, it is a volume guarantee mode. So volume guarantee, when we choose the volume, the pressure requirement varies depending on the lungs condition. That should be your message to the audience, so that you will know that the requirement may be 21, you set it, but it may require depending on the baby's lungs condition. So you are saying 21 and requirement also 21. So is some condition, can you guess it why it happens? Maybe
Like
you will.
Srikanth, one question.
Yes,
Looking at the
yes, sir.
ABG, the 7.19, so what do you think is the reason?
Sir?
Looking at the blood gas
Yes, sir.
and the settings,
Yes, sir.
where do you place the problem?
Sir, it will be respiratory acidosis.
Yeah, so he has a respiratory acidosis. So what could be the reason? Baby is now around 36 hours. Huh? What did you say?
39 hours of life, sir.
like around 30, 1.5 day. Yeah. So where do you play? What are the possibilities you will think of when you have a baby who is deteriorating at 39, 40 hours with a blood gas showing a respiratory acidosis? With PO2 seems to be reasonably okay, isn't it? It's
Yes,
almost
sir.
very, PO2 is 72 and an FiO2 of 30%.
Respiratory wise, the more accumulation of CO2 causes vasoconstriction.
I am asking the reasons for basically respiratory acidosis. You understood my question? When you have a pure respiratory, this is a respiratory acidosis without hypoxia, isn't it?
Yes,
There
sir.
is not much hypoxia in the baby. So what are the reasons you will think when you have a respiratory acidosis without hypoxia?
You have a FiO2 need of only 30%, no, Shrikant? And you
Yes,
have a
yes.
good CO2 of 72, but you have a high CO2, which is affecting the pH as well. So what bedside,
Any central cause of
okay, but you've supported him, no? You're giving him some rate, some backup rate is there. What could be the reasons why he's developed a CO2 retention in the lung, in the tube?
ma'am, like first we need to rule out tube block.
Very good.
So
24
whenever you have
days
an isolated CO2 retention, we should think of tube problems
Tube
first.
block.
Okay, airway problems basically.
Able.
So airway includes, because it's an intubated baby, so you should look at the ET tube, secretions, position. So almost
Yes,
like a dope. Okay,
yes, sir.
may not be an immediate deterioration, but you should think of airway issues.
Yes, sir.
Okay, so whether the tube is in position or not, whether there are secretions blocking the tube. Okay,
Yes,
then
sir.
the next thing, as someone suggested, is there any air leak? Okay,
Yes,
so
sir.
air leak usually has some requirement of FiO2 also if it's like a massive air leak.
Yes, sir.
Okay, so here the CO2s are, PO2s are reasonably good. So we should always think of airway problems first.
Airway.
Right.
Yes, sir.
So can PDA cause such a phenomenon? 24 weeker is 39 hours. Can PDA trouble the baby like this? Can PDA cause respiratory acidosis?
When it is of moderate size of PDA, it might.
Okay, go ahead, no problem.
And coming to the investigations wise, hemoglobin level of 12.3 and platelet, they were decline in the platelet count, and it is of 1.55 and iron of 1.5 and APTT of 53. They were, and NSC has showed right-sided grade 2 IVH measuring 17 into 13 mm with 50% of right ventricular volume. On 24 hours of life, baby was continued on HFO with frequency 11 and MAP of 10. And delta B of 20 and FiO2 of 23, and BP was central for 98th centile, and baby was not on inotrope. And coming to the investigations, and like NSC has shown
Before going to
right-sided grade 4.
Srikant, so hold on. Before going to investigation, during a presentation, we did not get an idea why you or your team chosen a HFO ventilation when the baby from the conventional ventilation to HFO shifted. That's why we didn't get an idea probably. You told us the setting of HFO, but we didn't get it. From previous slide. You can explain what are the situation when you will choose. No, this probably the conventional ventilation is not good for the baby. I will go for HFO now. So from the previous slide, you can keep and explain so that we will understand why suddenly somebody had changed to HFO.
The requirement of ventilated settings were more, and that is also like we are on high settings of PCAC with VG mode, and more CO2 like more CO2 retention is there.
But high
That-
means at
so that-
what high level? What high level of conventional setting? Because as Dr. Shram has highlighted, this is a pure respiratory acidosis. We sort out other issues like clear the secretions, shorten the tube sometimes. See there is a kinking of tubes there. Other factors to correct may be corrected also. The PCO2 comes down. So it is so you have to say that persistently what ventilator need will trigger you to change from conventional. All this is a message to all. I am with the extreme small babies, 24 week to 26 week or 27 week, I'm ventilating. At what ventilation setting I will think, okay, this conventional ventilation setting is high for this baby. It is maybe more damaging. So if we will rescue HFO, I am planning at what setting I will plan for a rescue HFO, because primarily this baby was ventilated on conventional ventilator. Now I am switching over to HFO. The term is known as rescue HFO. So what are the setting where I will think of, okay, this baby might get benefit from rescue HFO rather than continue with a higher setting of conventional ventilation. What is that cutoff? When I can take the call? It is this question for all the trainees who are attending also. You can answer in your chat box that what conventional setting you will think of, okay, this conventional setting is high. This may be damaging to the baby. I want to be more gentle. I will switch over to HFO. Which setting should trigger you?
For a preterm baby, PEEP of 6 and PIP of 21.
So any PIP cutoff, mean airway pressure cutoff, any FI2
Like
cutoff, anything there? So usually
like
when we
22,
say
20.
extreme small babies 24 26, again I'm reinforcing here. FI2 need, if there is a FI2 need is there higher and higher, parallelly there is a mean airway pressure also increase there. So if the mean airway pressure, some units in extreme small babies mean airway pressure 8 or more than 8, and some units 10 or more than 10, they decide, okay, maybe the HFO will be gentler way of ventilation, I will switch over. Or the PIP in a small babies, extreme small babies 24 to 26 with PIP up to 20, and in the late preterm babies or moderately preterm babies, maybe 22 to 24. So different units will have a different protocol, but we should have our own protocol, because should not be randomly, it should not be somebody changed from conventional to thought of the HFO is going to work. Every unit should have a protocol. It may be 1 or 2 number may change, but by principle we should say, okay, this baby required 4 ml to 5 ml per kg, I'm going to 5 ml per kg, but pressure requirement is higher and higher. This higher PIP might be damaging. At this cutoff, we will switch over to. Or some units may prefer, I will go with the tidal volume a little higher, but managing in conventional ventilation. But there should be uniform protocol across all the care providers. That's the point. But a standard protocol rescue HFO for a small baby age, 8 to 10 MAP, it is crossing 8 to 10 MAP. Think of once rescue HFO. Or PIP in extreme small babies 20, or little moderately preterm babies maybe 22 to 24. If this PIP requirement is there for ventilation, to get the normal carbon dioxide, physiological carbon dioxide level, we are requiring a higher level of PIP. We can think of rescue HFO. That should be the point, cutoff point we should know. So this baby is any second dose of surfactant given for this baby? Did you present? I missed probably.
So no, sir. Like 1 setting of surfactant was given.
So higher setting requirement is there. At which point of time, past 24 hours of assessment, you will think of, okay, this baby, I have given 1 surfactant. This extreme small babies might get benefit from a second dose of surfactant. At what point you will assess and what cutoff you will think of? Because not giving surfactant needed and giving higher pressure is damaging to the lungs, damaging to the brain, and damaging, the inflammation, the cascade or oxygen injury cascade starts. If really required a second dose surfactant, sometimes putting second dose surfactant will rescue the baby. So you all should know in such extreme small babies when to use the second dose of surfactant.
So like if there is a requirement of FiO2 greater than 5 in the past 24 hours and right off.
Can qualify that one step better, I think, Shrikant. Just 5% increase is enough. Suppose baby was on room air and he
Greater than 5 now.
Okay, so if the baby was starting on room air, 21%, 25% is maintaining, and then now he requires around 25-30%, will you consider second dose? So it should be reasonable increase, no? So 5 is fine if he was sitting on some borderline brink, probably. With some standard guideline or consensus you could just quote, maybe 30% or 40% FiO2 the increase in FiO2 need beyond, not increase from baseline. Increase in FiO2 need beyond 30% or beyond 40% and persisting that way, then you could consider a second dose of surfactant. Okay?
Okay.
Good. Dr. Nidhi is answering. Dr. Nidhi is probably few of the trainees are answering right. So, and Dr. Nidhi has answered rightly. If I understand, if after second dose of surfactant, so one of participant, they told 30%, one told 40%. Probably the 30 to 40% range we have to agree. Absolute number is not important. But along with the trainees, I am happy that they answered the mean air pressure requirement 8. Because I am using 22 pressure or mean air pressure creating 11. My FI2 may come down to 25. If only oxygenation cutoff I will take, using higher pressure, I can achieve lower FI2, but that's more damaging. So the guideline always speaks about a mean air pressure plus the FI2. So FI2 30 to 40% with a mean air pressure crossing more than 8. Mean air pressure 8 means almost 20, 21 PIP I have to use. With that much pressure requirement, probably thinking for a second dose surfactant might be helpful. So answers 2 of the trainees is given right answer. So with that probably you can continue further. With that, Shriram, just I am in between. I am putting few of the break because the discussion is for the learning sake. But you can proceed and take the discussion further.
No problem.
Srikanth, you can go ahead.
Yes, yes, sir. At 74 hours of life, baby was continued on HFO with the like on BP were 90th centile, baby was not on inotropes. And coming to investigation part, NSG has shown right-sided grade 4 IVH occupying 70 to 80% of ventricular volume with extension into periventricular deep white matter on the right. And coming like
So what is
coming to
it
the
called as?
so that is of grade 4 IVH.
Grade 4. We usually call it as. Extension into the periventricular area is called as.
Any other acronym?
Any other name?
Parnika. Parampreet. Yeah. So usually it may not be just a hemorrhage, no? It might be a hemorrhagic infarct. Periventricular hemorrhagic infarct.
That's why the grade 4 is usually not used, isn't it?
Yes, sir.
So it's a separate entity.
Yes, sir.
Yeah. So can you have grade 1 and PVHI? Is it possible?
No, sir. Grade.
No?
Yes, no, sir.
Is it always a sequence from grade 1, 2, 3 and then PVHI?
Grade 3 and grade 4, sir. That causes like periventricular hemorrhagic infarct and periventricular like post-hemorrhagic ventricular dilatation.
Grade 1 cannot cause PVHI?
No, sir.
You can
Is it in the
say
chat?
more diplomatically, less likely. Yeah. Because why are you doing these scans actually? Because it looks like the baby is pretty not bad, no? Even you said there's no catastrophic manifestation of the IVH at current state. Why are we doing ultrasounds then? I mean, you're doing at 24 hours, 72 hours, whatever. What is your purpose? If the baby is clinically not looking like he had a major bleed catastrophically, suppose he was just crashed, then okay, you want to know what happened. Otherwise, why are you doing?
Less than 32 weeks and usually routine scan like routine scanning is done at 3 days of life.
For what?
And previously, like
what is the post-test management change, or what is going to change if you find an IVH? What is your premise? What is your goal in finding an IVH? You did a scan, you found an IVH. The baby is not currently tachycardic, he's not hypotensive, he's not seizuring, he's quite active. Then what was the purpose in you doing the scan and finding the IVH? Somebody has already put one answer. What are you looking for? I mean, what will you anticipate? If your baby has IVH, what does it change for you, for the baby?
Hemodynamically, like if unstable.
Very good. So you can anticipate the baby can become unstable because of this. Yes, then.
And neurologically, seizure, like we can, like seizure, like seizures, like they might be the activity of seizures and
CNS manifestations can happen. We can watch for those also. Then.
yes, seizure.
Is there something which changed? Huh.
Clinically, hypotension, pallor,
Done. You already
and
said.
there were chances of apnea.
Yeah. So hemodynamically, baby can change. CNS wise, baby can change. In clinical presentation, in the acute form. What else are you doing the scan for? Are you trying to predict something? Are you trying to look out for something distant from here?
Complications, ma'am.
Very good. Like,
Uh, Periventricular, like hemorrhage, in fact, and
very good. So that
periventricular,
can
like
lead to, if you have a PVH,
post-hemorrhagic,
it can lead to post-hemorrhagic.
post-hemorrhagic, in fact, ma'am. When
Okay, so
and
you're missing two things, but I got your point. You might be wanting to look for cysts later on because it becomes necrotic. That's one. Other one is post-hemorrhagic what? Other complication is?
other complication, periventricular dilatation, ma'am, post-hemorrhagic ventricular dilatation.
Yes. So post-hemorrhagic hydrocephalus, right?
Hydrocephalus, ma'am.
Yeah. So you can anticipate these two things and you might want to or not take action based on those. So you have
Yes,
3 or 4 goals of doing the ultrasound, no? You
Yes,
do
ma'am.
on day one because you think that probably there has been some perinatal injury and it may affect the course of the baby. Second, third day you're doing because you expect that this baby may deteriorate and you might look for problems associated with that. And if the baby has already deteriorated, then you might want to explain some of it because of this. Third is that once you find a bleed like that, it makes you want to look out for signs of PHH or PVH later on. Okay. Then what will you tell the parents if he was standing there, if they're standing there, Shrikant? Is this good, bad, not good?
Grade 4 can consider it as bad, ma'am.
How will
Like
you
if it
tell them?
complicate,
They just came to you when you were doing the scan, you found this, and they asked you, doctor, what is the finding and what does it mean for our baby? In plain language.
ma'am, there was an increase in the size of the that hemorrhagic part, and like we'll be counseling about the size of the increase in size of the hemorrhagic part, and less likely that will be resolving,
Okay. So you mean to say that
and there might be complications of there are chances of complications.
yeah. So do you tell them that then there is no point, let's withdraw?
No,
Suppose.
ma'am.
No. So which
No.
means what
And
would you prognosticate scientifically in your brain and how will you tell them that? You can't doom the baby, no? Because the baby is not doomed. You said you sent the baby home, no?
yes,
He's
ma'am.
no? Yeah.
Yes,
So which
ma'am.
means what? All of them with grade 4 IVH do not die, right?
Yes, ma'am.
Yeah. So what is the chance that the baby will survive? You put it that way instead of saying baby will die.
Ma'am,
So
in intraventricular hemorrhage, there might be 50%, 45% of chances of progressively increasing, progressive increase in the
good. You're going well.
ventricular dilatation,
Yeah.
and there were chances of 10%. There were chances of arresting,
Okay. You mean to say that it may not progress.
yes, ma'am, may not progress.
Okay. Good.
And if
How
it
fast- Well, okay, you said good, nice 2 points. One is that there is a chance that this thing may extend. Okay,
yes,
we
ma'am.
might have to watch over a few days, but there are also good chances that this baby's bleeding may not extend also.
Yes, ma'am.
Okay, it may stay put. It may get arrested is a word that might be negative for parents. So you can
Okay,
say
ma'am.
that it will stop becoming bigger, make it easier for them to understand. And then we might have to watch for certain complications that if we detect earlier, we might be able to help the baby with. So give them some positivity, Shrikant.
Yes, ma'am.
You say that yes, there's this problem, the scan is not normal, but it doesn't mean that the baby has to be bad because of this. There are some babies who do well in spite of this. And this finding helps us to look for problems and detecting them and treating them earlier. Does that
Okay.
make sense? Even if
Yes,
you
ma'am.
don't actually put percentages.
Okay,
If,
ma'am.
suppose 50, yes, tell me what is the mortality associated with 24-weeker with grade 4 PVL, or grade 4 IVH, sorry. What would be your rough or from what you have read?
2 to 5%.
Grade 4 PV, IVH.
2
It
to
will be
5%, ma'am.
It will be much higher than that. It will be probably 40-50%. Okay, as such, 24 weekers mortality is not very low. Okay, survival is good now. You can keep it at 80% probably. But if you have a grade 4 IVH, then that chance of survival slightly drops, right? Yeah. So you can say chance of survival is still 50%.
Yes, ma'am.
Yeah. So you don't tell them chance of mortality is 50%. You can say chance of survival is
Chance
still
of survival.
50 to 60%. Okay.
Okay.
Yeah. So that's how when you're reading long-term prognosis of a particular problem, you have to know how to interpret it and tell the parent. You're going to be a practicing neonatologist, no, Shrikant?
Yes, ma'am.
Yeah. And tell them in slightly positive ways, because what is your intention? You're still going to continue intensive care, no?
Yes,
For this
ma'am.
baby. Yeah.
Yes, ma'am.
You have to have your own scientific judgment and scientific justification for doing that. Otherwise, you're doing ethically wrong things, right? So you know that this baby is not doomed. He still has a chance to do well. And you tell the same thing to the parents. Sriramji, Alikanji.
Yeah. Apart from mortality, is there any other risk the baby survives? Yes.
What are you following up the baby now for, Shrikant, when he is coming for follow-up?
Like increasing the head size, ma'am,
Yes.
and activity-wise,
So
Is
what
the
is
baby
our
at risk
baby
of something
asking?
in the long term, apart
Yeah.
from suppose the baby survives? So is he going to do well in the long run?
cognitive,
Good, good.
there might be cognitive impairment, like
Cognitive you will be able to assess in the immediate, I mean, at 1 year.
no, sir, in 1 year.
The first 2 years, what you will be able to assess?
For the for the start, like initial 1 year, like will be routinely screening for any ventricular dilatation.
Yeah. So acute complication would be hydrocephalus you're looking for.
I do, yes, ma'am.
And apart from cognition, anything else? Can this baby become cerebral palsy?
Cerebral palsy, yes, ma'am. Like
He-
post
Yeah.
periventricular hemorrhage, in fact, might be there were chances of CP and epilepsy.
Yes.
What type of CP if it is only PVHI?
So that will be spastic diplegia.
So where is it?
Grade
PVHI, is
4
it
will be
bilateral?
bilateral will be quadriparesis, sir, and unilateral will be spastic diplegia.
Diplegia, na? Diplegia means?
Can this baby become hemiparetic? He can.
Yes,
Okay.
ma'am.
Yeah. He can be any form of CP, really. Like you said, he can be spastic quadriplegic, he can be spastic diplegic, he can be spastic hemiparetic. Because PHI is not a lone entity, no?
Yes, ma'am.
Associated with other underlying white matter damage, it might not be just in that region. He might be an evolving PVL. Even if you can't find any cystic lesions in the ultrasound, you might still be dealing with the preterm brain injury in the white matter or in the deep gray matter, right?
Yes, ma'am.
Okay.
But most likely it will be hemiparetic, isn't it? If it is a pure PVHI,
Unilateral.
the rest of the brain is normal, then he is most likely to have a hemiparesis rather than
So again, how will you put that positively to the parents, Shrikant, if you find that this baby is at risk of having some spasticity? You would want to tell them what in better words? They'll ask you, is my baby going to be normal? One is we talk about death, that's over. We talked about death. How do you tell them about long term or not even long term, 1 year? Is
They will be less likely, or there were the chances of cerebral palsy or
okay?
less likely?
And yeah, how it become less likely? Is the IVH of grade 4 is a
Why, yeah.
protective in a 24 weeker baby? Is the IVH of grade 4 is the as such a 24 weeker baby will have its own disability without any IVH PVL also. We know its mortality is higher, and in comparison to a bigger baby more than 28 weeker, the developmental delay in the form of motor delay, the hearing and the vision delay, and the cognition and speech delay are little higher in a 24-weeker, irrespective of in absence of IVH PVL. Then by getting, you are getting a third day or second day diagnosed a grade 4 IVH. So it lessens any of the morbidity in the parents.
Oh, sir.
So how it is going to lessen the morbidity? So the counseling form, what can happen in extreme small babies before delivery, or it is a normal delivery, you just see imminently deliver. That time must be the interface when counseling happen in a 24-weeker baby. So 24-weeker babies, the expectation should be the realistic and should be explained beginning. So this is adding another morbidity. So we should be clear. Tomorrow, a 24-weeker baby or 25-weeker, 26-weeker baby, additional neurological risk factor in the point, whenever it happens in that particular point, we should be clear and we should be explaining to the parents. You cannot say hide any facts. You cannot say this may not happen anything. No, we should be clear with our scientific facts. With that, parents from before they know 24-weeker, still they continue because of their expectation or their whatever the social background. Now they have, if accepting and continuing, only you can continue. Or knowing a bilateral grade 3 or unilateral grade 4 IVH or a periventricular infarct or a hemorrhagic infarct of the parenchyma, we should be clear our prognosis. The point here, now there is a pathology. We should be clearly understand the pathology and should explain the family. We cannot say it is a protective, it will happen less. No. Now we have to say whatever the morbidity chance we explained before, now this factor may additionally increase few of the morbidities.
Okay.
We have to clear our prognostication. So, and the particular, the way Dr. Sriram has highlighted, I will say if you are expecting a unilateral pathology, explain. There will be a pathology, but likely that will be unilateral and other parts may be okay. But if a bilateral pathology, explain. The bilateral pathology is going to cause a more morbid condition. From beginning, we have to clear about our prognostication. If I understand the pathology clearly from beginning, okay, this baby is bilateral pathology, vision affected, both side might affect. The hearing will affect, both side might affect. Motor, both side might affect. And from beginning, I know, okay, it is severe degree, but it's a unilateral pathology, might escape the other parts. That's a positive thing you're explaining. In all the negative point also, you are seeing something positive. You say, okay, there may be unilateral pathology, one side of the, if right side pathology, maybe left side will be affected, left side pathology of the brain, right side will be affected, contralateral side, but other side might still work motor-wise. And the vision, hearing, we follow up, we will know that. That's way to speak, but you cannot say it will lessen the morbidity and lesser morbidities you're expecting when the degree of injury is higher. We should be clear on prognosis. That's the message.
Okay.
So every point of time, you should be transparent to the family. Then it won't cause any issues later. Because 24-weeker may be new in India, but 24-weeker, 23-weeker, 22-weeker is many of the higher center, tertiary quarter center of ICUs, they take care across the world. And these morbidities are common. But we will be clear to the family first.
Okay.
So you can next slide. Are you going to next slide? Anything you're showing here?
And like we'll be grading IVH, sir. IVH classification, that is a Volpe classification. In the grade 1 geminal matrix image with without minimal IVH, and grade 2 will be interventricular hemorrhage occupying 10 to 50% of ventricular area on the parasagittal view, and in the grade 3 interventricular hemorrhage occupying greater than 50% of ventricular area on the parasagittal view, and usually distance lateral ventricle. And coming to the other classification, LFD classification, and this will be the squaring of highest traditional GMH IVH classification, IVH grade, and in that like as per papillae will be grading as 1, 2, 3, 4, and in LFD classification that will be the squaring of these 1, 2, 3, 4. That will be 1, 4, and 9 and 6. And if it is involving into the contralateral side, then it will be the, then we need to add that. And normally like before like usually we'll be dividing that angled parasagittal view into 5 territories, and 3 maxillary lines that will be dividing it into 5 territories. And if there is an involvement of greater than 2 territories, and we need to add 5, And if there is a midline shift of the brain, then we need to add 5. And these territories will be referring to the brain regions from the system of Basin. And scores will have a maximum value of 35. And it will be for a bilateral grade 4 with a midline shift involving greater than 2 territories in either of the spheres. At 96 hours of life, post-menstrual age of 24 plus 5, baby was continued on PCAC mode, and BP centils of greater than 95th centile and minimal aspirates were present. And during the course, there were persistent hypertension and IVH, and hence calcium channel blocker Nicardia has been added. And coming to the investigation part, HB was 9.4, it was declining, and NSG it has shown the same right-sided grade for IVH, and 2D echo it has shown no PDA, and USG abdomen to it has shown normal renal Dopplers to rule out any renal cause of hypertension. And during the course, on the day 8 of life, baby was shifted from HFO to SAMV with VG, and there was a culture positive sepsis, candida, and antibiotics were escalated at day 11 of life, and there was neonatal jaundice with hyponatremia with apnea of prematurity with persistent hypertension. On day 15 of life, post-menstrual age of 26 plus 1, over the course, the baby was on minimal ventilator settings, and repeat neurosonogram has shown right-sided grade 4 IVH with bilateral ventricular dilatation. In the view of post-hemorrhagic hydrocephalus, severe lumbar punctures were done, and hydrocephalus persistently progressed in the severe neurosonograms, and head circumference progressively increased over the period. And during the course, like we'll be monitoring serial sonograms by monitoring ventricular index. In the right, it has shown at the 20 around the 26 post-menstrual, there was increase of head circumference plotted at 97 plus 4 mm, and left ventricular also there were increase in ventricular index of 97 plus 4 mm. And usually, like this cranial ultrasounds, that will be done to quantify the rate and severity of ventricular dilatation. And there were indexes like we'll be discussing about ventricular index, anterior horn width, and thalamo hospital distance, and resistive index. And cranial ultrasound will be performed at least 2 to 3 times per week until the ventricles are stable for 2 weeks. Then every 1 to 2 weeks. And the first one, ventricular index, that will be Levin index, most frequently used for monitoring ventricular size, and it is the distance between the FARPs and the lateral wall of the anterior horn in the coronal plane at the level of third ventricle, and it starts to enlarge in most severe hydrocephalus and may fail to identify mild ventricular dilatation. And usually, like we'll be grading post hemorrhagic ventricular dilatation pre-ventricular, that will be ventricular index will be exceeding greater than 97th percentile, and severe PHVD ventricular index will be crossing greater than 97 plus 4 mm. And the other one is of anterior horn width, and it will be the diagonal width of the anterior horn measuring at its widest part in the coronal plane. And this is the most sensitive marker for mild ventricular enlargement. And the first sign of increase in ICP is rounding of the frontal horns and the increase in anterior horn width. And in moderate PHVD, it will be greater than 6 mm, and severe, it will be greater than 10 mm of anterior horn width. And other one is of thalamo hospital diameter. It is the depth of the hospital horn to lateral ventricle. It is the distance between the outermost point of the thalamus at its junction with the coat plexus and the outermost part of the hospital horn in the parasagittal plane. And it ranges from 8.7 to 24.7. And in BHVD, that will be greater than 25 mm. And other one is of resistive index. It is a pulse wave Doppler of anti-cerebellar artery, and that will be calculated systolic minus diastolic by systolic, and normal values were less than 0.7, and that will be monitoring cerebral hemodynamics. And in PHVD, initially a rise in the systolic flow followed by the decrease, and absent or inverted even inverted diastolic flow is also seen. And if the RA index is greater than 0.85, there will be rise in ICT, and delta RA greater than 45% correlates with the ICP, and there will be a need for the shunt. At day 35 of life, during NSU stay, baby was weaned off the womb and continued on OG feeds, and blood culture has shown like a positive for Candida albicans, and culture has shown no good. Then CSF PCR was sent and it has shown positive. Hence, antifungals were continued for 21 days. And USG abdomen and examination has shown no signs of end organ dissemination. In spite of serial ventricular tapping once in 2 days and increase in head circumference and ventricular index, BB was planned for subgaleal shunt placement. And in the CT also, it has shown moderate dilatation of both third and fourth ventricles with ventricular syphilic ratio of 49, with the maximum diameter of antihorn of lateral ventricles being 13 on the right and 13.6 on the left side.
Why did you choose a CT? Just curiosity, Shrikant.
Ma'am, to look for any any suspicion of septations and loculations, then we have done CT head.
What would be the, as an exam question, what would be the investigation of choice for
Cranial
neuroimaging
ultrasound, ma'am.
that you've done? And
Yes,
anything else?
ma'am. And MRI, ma'am, diffuse weighted.
Yeah. What advantage does MRI have over CT? Very obvious one in this baby.
Ma'am, any in MRI, like if there is any hypoxic ischemic injury,
Okay, so you can't make out white matter damage and preterm
white
vein
matters, ma'am.
from CT scan. And
Yes,
the
ma'am.
other obvious one is CT is radiation, right?
Yes, ma'am.
Growing brain. Yeah. So we usually don't prefer CTs. I'm just
CT.
wondering if your neurosurgeon asked for it or.
No, ma'am. Like we thought of looking for septations or inoculations to rule out those.
Okay. Shrikant, why did you do serial LPs and not serial ventric taps? Ventricle is big, no? You could have just taken it out from there only. You've done serial LPs first, no?
Ven-
That's what I understood initially. Or was it serial ventric taps from the beginning?
ventricular tapping.
Okay. What is the problem with serial ventricular tapping? Why can't you keep on doing that instead of putting a VSG? Instead of putting a ventricular subgaleal shunt, why
Yes, ma'am.
can't you just continuously keep doing ventricular tapping? What's the problem with
In like there were chances of phase of arrest, and
sorry,
and the we are considering the prematurity level and weight of the baby.
okay. Why does a clinician not want to do too many ventric taps, Shrikant?
Chances of infection, ma'am.
Okay, very good. So you're putting a needle straight into the brain, and the other one is each time you're creating a tract through the brain, right? So your
Yes,
needle
ma'am.
can create trouble each time you ventric tap.
Yes, ma'am.
Why will you not do a serial LP instead of a ventric tap? Let me reverse the question. Why can't you just do in what situation will you do ventric tap instead of a LP, serial LP? You can do LP, no? Isn't it more safer? You're doing it low down. You're not putting a needle through the brain. You can do a serial LP, no? Lumbar puncture. Is there a situation where you will not get what you want by LP? Somebody's put the answer there, no? So
Yeah.
if you have an obstructive hydrocephalus, you may not get a result from a serial LP, but usually post-hemorrhagic type of hydrocephalus are not obstructive. Most of them are communicating types. So you might be able to manage or pull it off with just doing serial lumbar punctures itself, rather than doing serial ventricular taps. Okay. How many times, just again curious, how many times did you do ventric tap or LP together? How many times did you attempt conservative before you took a decision for a shunt?
Over the period of 2 to
5 times, 6 times, 10 times, somewhat? Any number? Okay. If you were managing this baby, Shrikant, and you had the chance to decide whether to place him for a shunt or to do a serial tapping, how many will you use as a limit? It doesn't have a right answer, my question. I'm just finding out what is practice. That's all. Now,
2 to
okay, 3 times, 5 times?
3 times, ma'am, like 2 to 3 times.
I'm just using my number only. 3 to 5 beyond, I would have been a little uncomfortable, but maybe
2 to
this is
3.
the reason why you may want to do further. Suppose your baby is not amenable for a ventricular subgaleal shunt placement. He's too small. Your neurosurgery team is not ready, or if your proteins are very, very high. There may be some reasons why you don't want to put tape shunt. Okay, so there's no number, there's no cutoff number, but too many also is not good. Too many taps. Okay. Yeah.
Srikanth, actually, I will ask a question a little bit
Yes.
to clarify things. Last question. The way Dr. Pramita is asking number, we don't have a number. We know that there's no specific cutoff number. But a baby which 1.6 kilo, another baby is just 900 gram or 850. You diagnose hydrocephalus, but that time baby is 850 grams with a 27-week PMA, post-menstrual age. And the neurosurgical team is worried about placing some ventricular subgaleal shunt, which can erode the skin also, scalp skin. When a simple IV line also can cause extravasation, putting
Yes,
a instrument sometimes causes pressure necrosis of the skin. Another baby is 1.6 kilo, 1.7 kilo, I can put happily. So there the approach will be different or the same. We will fix some fixed protocol and we'll go for ventricular tap or lumbar puncture.
So considering facility of the like skin facilities also.
So what the Pramita is giving clue to you, your neurosurgical team is they are ready. Is the baby is ready. Baby means baby's maturity and baby's ventricular. When you're doing ventricular analysis, tap analysis, you are getting 300 protein level. So such a ventriculitis, active ventriculitis is going on high protein level. Sometimes people are worried to put any form of shunt, it may block. A ventricular subgaleal shunt also can block. A BP shunt also can block. So a active infection at that time also nobody wants to rescue, put an antibiotic or antifungals, and once the baby stabilized, then can go full. So during that phase, probably buying time, these interventions of ventricular tap or lumbar puncture tap probably going to helpful for buying time. But whenever there is an opportunity to go for a definitive subgaleal shunt, we can put it, or a bigger baby when we VP shunt directly put it. Probably that should be the right answer because we know this is a chronic issue going to stay for long. We have to handle it. Okay. So it is not number, it is the timing and the baby's maturity that mainly decides how to go for, when to go for.
Nalini, your neurosurgeon is online. We can learn from him, I think.
Is there?
Yeah, Dr. Praneeth.
Pranit.
Is there? Dr. Pranit, are you there around?
Oh. Okay.
So
We have a technical problem.
I will try. I don't know. No, I cannot do that. That's the technical team has to do.
Praneeth, can you
In the
just
meantime, when the discussion going on now, I will send a link actually to Dr. Pranit.
Okay,
So,
that would be great. Yeah.
so further you can present. In the meantime,
Yes,
we will
sir.
see.
Yes, sir. And coming to the differentiating between the ventricular access device and ventricular subgaleal shunt, and usually they tapping required for every 2 to 3 days for ventricular access device, and that will be less frequent for the ventricular subgaleal shunt. And in like considering ventricular access device, there will be skin facility is one of the main issue, and it will be clearing hemorrhagic CSF. And coming to the ventricular subgaleal shunt, and multiple sites can be used alternatively, and CSF gets absorbed into subgaleal space. On day 37 of life, post-menstrual age of 30 weeks plus 1 day and weight of 0.69 kgs, ventricular subgaleal shunt was placed, and preoperatively head circumference was 27, and post-operative was 23.9, and seen like preoperatively AF was full, and NSG also showed mild to moderate dilatation of both lateral and third and fourth ventricles. And postoperatively, AF was at level and activity has increased, and NSG has shown both lateral third and fourth ventricles are normal and no hydrocephalus.
Wow.
Let
Close to your neurosurgeon, really, Dr. Praneeth, for doing it on a 690 grammer.
Can I continue, ma'am? Can I continue, ma'am?
You can continue. I'm saying Dr. Pranita said the link actually. If he is joined, he can share some inputs to us.
Later on, baby is on feeder and go. In the NICU stay, had another episode of culture positive sepsis, Klebsiella pneumonia, and there were no meningitis. And it has been responded to injection meropenem, and weight gain was from 650 grams to 1.99 kgs in over the 73 days. And MRI brain was done, and it has shown multicystic obstructive hydrocephalus and obstruction of the aqueduct and foramen luska, and primarily due to post-hemorrhagic sequelae. And at day 111 of life,
Shrikant, 1 minute here. We were discussing, in this kit, we did almost 3 LPs, followed by 2 ventricular taps before we decided upon a VSG shunt.
Yes, sir.
And, we were always counseling about the parents regarding this guarded prognosis and everything. The
Yes,
CT
sir.
was also done in the same way. Here we see very poor mantle. There is a lot of thinning in occipital region and dilatation. We were always telling them about this guarded prognosis. Being a precious kid, they want to continue treatment. So
Yes, sir.
after explaining about cerebral palsy and everything, still they want the baby to be treated. So we continue this kit.
Yes, sir.
And regarding the VSD versus VAD, as Dr.
Yes.
Nalnikant sir was rightly saying, in the small kids, we will not be able to put a Omaya because
Yes, sir,
as they
Omaya.
were also, skin is very fragile. But
Yes,
in
sir.
infection or when there is a high protein, still we can put a VSG shunt.
Yes, sir.
The block rates will be high, but still VSG shunt is not a contraindication
Yes, sir.
because we will not be able to shunt these kids at such a young age. We need to wait till they gain a weight of 1.5 kg
Okay.
and this proteins or whatever, if there is an infection, until they settle, we will not be able to do a definitive CSF.
Yes,
Please
sir.
continue.
At day 111 of life, post-menstrual age of 39 weeks, 6 days, and weight of 1.99 kgs. In the view of AF bulge and there was a poor feed intolerance, and repeat NSC showing dilatation of ventricles with good CSF flow in the subgaleal pouch, likely increased CSF production with improving body weight. Baby was operated, and programmable ventriculoperitoneal shunt were placed. And coming to the IVH, clinically, there will be fever, apneic episodes, and sudden hypotension and pallor. Neurologically, there will be chance of irritability, stupor, hypotonia, and seizures that might be focal or multifocal. Abnormal eye movements and signs of ICP will be present, that is of full fontanelle and vomiting episodes. Coming to the pathogens of IVH, and that will be cerebral flow fluctuation. It will be due to cerebrovascular autoregulation or PDA and hypercarbium and vulnerability of matrix capillary, and might be due like one of the like other one is of impaired cerebral dynease, that will be increased cerebral venous return and increased intrathoracic pressure. And other one will be the genetic, that will be vitamin K epoxide reductase complex and APOE2 and APOE4 and endothelial nitric oxide synthesis and fibronectin 1. And natural history of PHVD like in intraventricular hemorrhages, 25% will be slowly progressing ventricular dilatation, and 25% will have non-progressive ventricular dilatation, and 50% will be there will be no ventricular dilatation. And in slowly progressive ventricular dilatation, there will be spontaneous arrest of 40%, and there will be 10% or 10% of rapidly progressive ventricular dilatation that will be requiring ventriculoperitoneal shunt, and 50% will have persistent slowly progressive ventricular dilatation, and there will be like intervention of lumbar punctures with or without drugs. There may be 20% of arrest and 30% of rapidly progressive ventricular dilatation that will be requiring 40% of ventriculoperitoneal shunt.
So here lies your answer, Shrikant. You just
Yes,
need to
ma'am.
remember maybe 1 or 2 numbers only. If you
Yes,
have a
ma'am.
baby who has a severe IVH and who's already developed a ventricular dilatation, or you think that the baby is going to develop a ventricular dilatation, you can still tell the parents that there is a 40 to 60% chance that the baby may not become too sick. The baby may survive, and we might have to watch out for long-term and short-term complications. You remember one simple number, 40 to 50%.
Yes, ma'am. And these are the charts we'll be using for ventricular index and anterior horn width and thalamohospital diameter. And there was a proposed risk stratification that will be on the green zone, yellow zone, and red zone. And coming to the green zone, the key criteria will be ventricular size or ventricular index of less than 97th percentile with anterior horn width of less than 6 mm, and absence of the following, that will be absence of head circumference greater than 2 centimeter per week, and separated sutures and bulging fontanelles. And management will be observation and serial cranial ultrasounds like twice a week until stable for 2 weeks, then every 1-2 weeks till 34 weeks of post-menstrual age, and MI will be done at term. And coming to the yellow zone, the key criteria will be ventricular index greater than 97th percentile with anterior horn width of greater than 6 mm and T-body of greater than 25 mm with absence of the following. That will be head circumference growth greater than 2 centimeter per week and separated sutures and bulging fontanelles. And management will be referral to the regional center for neurosurgical review, and we need to consider LP for 2 to 3 times and cranial ultrasound 2 to 3 times a week and stable for 2 weeks, then every 1-2 weeks till 34 weeks of post-menstrual age, and neurosurgical intervention when no stabilization occurs, and MRI at term. And coming to the red zone, key criteria will be ventricular index of greater than 97th percentile plus 4 mm, and anterior horn with greater than 10 mm, with or without T-body of greater than 25 mm, or any of the following. That will be head circumference growth greater than 2 centimeter per week, separated sutures, bulging fontanelles. And management will be considering lumbar punches 2 to 3 times, and neurosurgical intervention including either temporizing measures or permanent will be VP shunting, and MRI at term. And coming to the management of post-hemorrhagic hydrocephalus group 2, it will be like progressive ventricular dilatation that will be moderate to severe dilatation. requiring severe lumbar punctures 2 to 3 times only maximal considered for temporization. And other will be the ventricular drainage, that will be direct external ventricular drain or tunneled external ventricular drain, and subcutaneous ventricular catheter to visuvoy or to the subgaleal or supraclavicle spaces, and ventricular peritoneal shunt or external third ventriculostomy and choroid plexus ablation. And coming to the management of post-hemorrhagic hydrocephalus group 3, if there is an rapidly progressive ventricular dilatation that is of moderate to severe dilatation, and like excessive rate of head growth and resistive index clearly increasing, they will be will be doing severe lumbar punctures that is considered for temporization, and ventricular drainage to divert external ventricular drain or tunnel external ventricular drain or subcutaneous ventricular catheter to visuvoy or to subgaleal or subclavicular spaces, and other one will be the ventricular peritoneal shunt. About the ventricular peritoneal shunt system diverts CSF from lateral ventricles to peritoneal cavity, and the criteria will be a stable infant with at least 1500 grams. Sir?
So there is already this time 9:40. So we have to close the session. It is long already 9:15. We normally close. So this the surgical parts, you can probably we understand surgical challenges and achieving in such a small baby is sometimes difficult. The procedures the neurosurgical team locally with the neonatologist team decides. So surgical things you can bypass if you want to. So the prevention is always better than really managing challenging cases. So if you are having some points for the prevention to highlight, you can go to that and we can switch over to the discussion and close it, because time probably won't permit us for go to more than 5 minutes.
And coming to prevention of IVH, that will be prenatal interventions. Like we need to give prenatal glucocorticoids, and care during infant delivery will be optimize obstetric care and prevention of prolonged care, and postnatal neonatal like optimize neonatal resuscitation, reducing the fluctuations in the cerebral flow, and correction of coagulation and bleeding disorders, and closure of PDM. And like the main thing like we need to consider is neonatal bundle of care for the prevention of IVH in the first 72 hours of life. Preterm, that is of 30, like less than 32 weeks and less than 1500 grams or more risk of developing hemorrhage. That like we need to maintain a supine midline with a neutral head position, and we need to elevate the head of the bed at least to 15 degrees to 30 degrees during the first 5 to 7 days, and we need to ensure minimal handling and minimal suctioning, and we need to avoid rapid flushes and blood withdrawal to the venous or arterial routes, and we need to we need to reduce the fluctuations in the blood pressures, and initiating additional interventions for pain or stress in the form of non-nutritive suck or oral breast milk or sucrose. And coming to the complications, there will be cerebral hemorrhage, cystic white matter lesions, and encephalic cyst, and non-cystic white matter injury.
So thank you, Srikant, to taking through the challenges of the case. And these extreme small babies, we do have those complications. We cannot say that without complication we can manage extreme small babies, but whenever the complication comes, we have to manage. And more importantly, before inviting both the faculties to say the concluding remarks of the session, I will say these all type of complications, when we anticipate the complications of these small babies, and we will implement the bundle, the quality initiative case to prevent it, then probably we can reduce the complication related to this morbidities. The morbidities happens means there's a complication is bound to happen later, maybe like a smaller extent or greater extent. So the prevention is the key. So if we are taking care of small babies, implementing those quality cares from the beginning, a few of the babies early onset disease we cannot prevent. It starts from the perinatal area, the compromised delivery is outborn. If the maternal sepsis, sometimes it induces the injury too early. Like this case, first 24 hours only we saw the IVH, and that's the first 24 to 48 hour maximum time it happens. So, but when during the care, the practices should be such a way that we can at least prevent. And I will just both the faculties I will request to highlight few of the practices what the students should take from the session. They should implement in their unit when they're taking the ELBW care, so that this type of complication morbidities will be less. Just I will request both of the faculties to highlight those few practices, so the learning points will be in that say the session, the learning points for the students. So
Sriram.
Dr. Sriram and
Okay. Yep. It was a good presentation. I think you should keep in mind, as Dr. Nalini has put out, preventive aspects, because once IVH happens, nothing much can be done. As you have seen in this case, only it goes on getting complicated, and more interventions and more interventions. So it should start from the antenatal aspect. The most important preventive measure is, I think you all know, it is corticosteroids. So still our state is still lagging behind in the corticosteroid uptake. So that you need to always concentrate, promote, and ensure that all premature babies do have mothers are given corticosteroids. And next is in utero transfer is always better. That's one of the important strategies that we should keep in mind. We should try to avoid premature deliveries in the periphery and then transport a sick baby. It's always a good idea to transfer a mother rather than transfer the baby after delivery. And during delivery, you should ensure that you do all the proper NRP. At most, gentle handling has to be done. So ensure that baby is handled very carefully during delivery, during transport from the labor or OT to the NICU. Should be very, very careful. And early initiation of CPAP will help in reducing the respiratory distress, so that we should take care. And management of PDA whenever it is needed, that also has to be done properly. And ventilation, if the baby needs, it has to be very gentle. So as far as possible, try to use volume guarantee mode. So volume ventilation, we have to ensure that has been shown to reduce the incidence of IVH. And we should very gentle handling. Nursing care is very important. No sudden change of baby position. We should not lift the baby, especially sometimes nurses lift the foot under the baby for changing diapers, so that we should avoid. Sudden changes in baby position has to be avoided. No boluses, not much. You should give very slowly if at all it is needed. So don't give boluses for every delayed CFT or something. Especially in small babies, bolus, we have to be very careful. Whether it is really needed or not, we should be assess that and then ensure that when you are giving, you should be giving very slowly these babies, and no hyperosmolar solutions like bicarbonate and other things which you should ensure. And of course, if seizures or anything is there, then we should manage them properly. So these bundle care, as he has put, so these things we have to keep in mind. So this will help in reducing the incidence, if not eliminating the incidence of IVH. Yeah, these are some of the points. I think, Pamita, you can add on.
Shrikant, well done. It was a difficult case.
Thank
Okay.
you.
Yeah, and you answered very well, actually. You just have to structure it a little better. Everything Sriramji and Nalinikanji have said, except maybe that resuscitation readiness, that you should be there as a team much earlier for the delivery instead of panicking in the last minute. Then probably the most confident person should take on the intubation of such a small baby. We can't teach somebody intubation on a 24-weeker. Then early control of other neuroprotective strategies other than just directly IVH. That will include prevention of acidosis, hypoglycemia, hypothermia, then severe CO2 fluctuations. It happens. It does happen when you're a sick baby. Prevention of pneumothorax. So these are some things which will have direct as well as indirect impacts on prevention, and if at all IVH does happen, on the severity of IVH as well. Well done, Shrikant. Good.
Thank you.
Excuse me.
So
This is
before concluding again, Dr. Praniti is there. So I will say from neurosurgical side, it's not easy to manage such a small baby when it happens. So when the team discusses the challenge comes in the counseling the family, and if you very positively say it will backfire, negatively you will start saying to people the prognosis, nothing will move positively. So keeping a balance, the team, when the surgical team, neonatology team speaks to the small baby's family, the challenge part is counseling, right? And the next challenge is definitely the managing the baby surgically and post-surgical ICU care. So Dr. Pranit, few of the points, your challenges in small babies, you can say what are the right candidates, who are the right candidates who should not actually leave them, and we should manage them at least to get the best care.
Yes. So my first submission would be there was a comment that why we were doing so much of frequent NSGs. These children will have an entity like called as benign enlargement of subarachnoid space. So if we are trying to look for the head circumference to increase or the AF to bulge, by that time we would have lost lot of cortical mantle. So in these children, we should be aggressively monitoring with NSG. And I would also, as you guys are leaders in neonatology training, this new NSG should be handy, and it has to be all these our trainees should be trained in doing NSGs, because not every time radiologists will be available. And I have seen children with grade 1 IVH progressing to severe hydrocephalus in a duration of 24 days. The child eventually comes to us, and when they say that we were never told by the neonatologist that such a morbid situation can happen. Now you are talking about cerebral palsy and everything else that could have been screened. Though the neonatologist was screening head circumference, AF, by the time the head circumference has increased to such an extent, there was already a lot of cortical mantle loss. So NSGs have to be done serially when there is a uh, diagnosis of IVH or risk factors of IVH. Once IVH is diagnosed, then clinical monitoring is essential, but it will be too late by the time we have a detection with head circumference. And in this child, as the parents were persistent, we went ahead with VSG, and the VSG fortunately worked us for almost duration of 3 months, and child gained the weight. And we did MRI before we proceeded to shunt, because we were very much apprehensive, and we were backed out with the kind of his total clinical scenario was there. So in that MRI, we could see that the brain was growing back, and more or less the cortex was looking good. Eventually, we don't know how the child would perform while he grows up into his young childhood. But as of now, the baby is doing good. In these children, what we usually do when we do a shunt is we do a programmable shunt. We keep the pressures very low and allow the wound to heal, and later slowly titrate the pressures with respect to ventricular indexes on serial monitoring, and we end up where we don't have overcrowding of the bones, and also we have a ideal kind of a ventricular size.
Good, Dr. Pranita, I appreciate your all the inputs. Before closing, probably Dr. Pranita is answering few of the questions to the audience questions, the training questions. And last question came before just last question. The came germinal matrix grade 1. Can it cause some progressive isolated germinal matrix bleed in neonates? Either of the faculty, if you try to answer this, Dr. Pranita, Dr. Sriram, germinal matrix grade 1 should be ignored, or only we look for grade 2, grade 3, or parenchymal bleed as per Volpe's classification, or grade 1 also can cause some morbidities? That's probably the question I mean.
You can probably put it broadly into milder types as grade 1, grade 2, and severe types as grade 3, grade 4. And a same thing for prognostication and for your own planning of follow-up. That grade 1, grade 2 is not completely innocuous. It can be associated. It's just an indication of other brain injury. The IVH itself may not cause problems directly, but it may be associated with ferrous-induced radical or a free radical damage, or it may be associated with white matter injury. So that also can affect the long-term neurodevelopment. So maybe around 4 to 5% of those who have grade 1 and around 7 to 10% of grade 2 can still have an attributably increased risk of mild to moderate neurocognitive problems later on in life. So it's not just because of the IVH, but it's a picture which is confounded why IVH happened, and that the baby itself is a small sick baby.
Fully agree with the points, Dr. Pranita's point of the monitoring and classifying the prognosis beginning. But I will just one practice point I will speak here. when the neurology in the NICU, we monitor the neurosonogram. And if the first 1 or 2 days you are getting GMH 1, 2, 3, whatever, but just I will suggest don't leave it there. Follow till at least 28 days. And the term equivalents so definitely will follow, but then higher pathology will follow weekly also. But I'll suggest for all the units who's practicing. Second day maybe GMH1, but if you ignore it, GMH1 mild, and as a 14 day or 28 days, we may see a progressive lesion. So if you are seeing some pathology, at least weekly once till 28 days, I will suggest the 28 days is the maximum evolution of the vessels happen, even the small babies. At least you do the follow. That's part I will say though, just maybe mild grade 1 bleed, but need a follow to say that concluding that okay, this remains in grade 1, so the prognosis later, the effect later may be less to the baby's overall developmental outcome. With this, probably we had a good discussion, I hope, and Shrikant presented the case well and the sequence of the cases. Unfortunately, morbidity happens, but it happens how we should learn from one case, how to prevent for other cases, and to optimize the managing the case. That's probably learning point in this case. With this last bottom line, I will say again, prevention better than the cure. That's the old dictum, applies pretty well in these situations. So all our practices should be goal directed towards the prevention. With this, I will take opportunity to thank all the faculties, both the faculties, Dr. Pramita, Dr. Sriram, and Dr. Pranit, also neurosurgeon, and thank Dr. Shrikant for presenting this case well in a comprehensive way. So thanking all, I'm closing the session today. We'll come back with a new neurology case in the next session. Thank you all. Good night. Goodbye.
Thank you. Thank you.
Thank you. Thank you all.